A very good morning to all of you. My topic today is how to mitigate the risk of a sudden obstetric collapse, how to decrease the seriousness, how to alleviate the effects of an obstetric collapse, which is a challenge for any obstetrician. Maternal collapse is defined as an acute event resulting in involving the cardiorespiratory system and or the brain, resulting in reduced or absent conscious level, which may ultimately or potentially a case of cardiac arrest and death at any stage in pregnancy and within 6 weeks after birth. For any obstetrician, it's a nightmare. Obstetrics, as such, is a high-risk specialty. Maternal and safety events can emerge at any moment. And when you deal with obstetric collapse, you have 2 lives in consideration. And then the ultimate aim is to resuscitate the patient. Physiological changes in pregnancy makes resuscitation difficult. This results in serious maternal outcome, the SMO, which may be, if you are lucky, a maternal collapse or even a maternal death. And that is for the patient's life. That is the concern about the patient. And what is our concern? The obstetrician's concern is the psychological impact of the bad event, the mental agony, the loss of confidence, the loss of self-respect. In Kerala, it may amount to suffering physical assaults and sabotage of the institutional properties, and the media interest, which is always negative when a mishap occurs, and the resulting reputational damage for yourself and for the institution, following which the trauma of the medico-legal implications and the financial burden which occurs. And what is your aim when you try to reduce the risk of an obstetric collapse? Patient safety definitely is our primary concern. And when I discuss this topic, it is not one obstetric collapse, a PPH, or an amniotic fluid embolism which should be in our mind. What should be discussed here is how to prevent an obstetric collapse, and when it occurs, how to lessen the risk, lessen the damage that is caused by an obstetric collapse. So it is not possible within this 20 minutes to discuss all cases of obstetric collapse. What I want to do is a general outline as to how to improve the outcome in a case of an obstetric collapse. And here, the risk management will involve the development of a multidisciplinary culture. Not that when an obstetric collapse comes, you run and find out solutions. And we should have a protocol and guideline when an obstetric collapse occurs. What should we do in each case? And that should be inbuilt. And that definitely involves the senior obstetrician, our trained staff nurse, and definitely people from other disciplines like a cardiologist, anesthesiologist, intensivist, neurologist, and definitely the transfusion medicine specialist. And what can be the cause of an obstetric collapse? Discussing the causes, I told you, is beyond the scope of this time, but then it can occur antenatally, intrapartum, and postpartum. And the causes could be something which is anticipated. We know when a PPH occurs, when sepsis occurs, when hypertension comes, all these causes can lead to an obstetric collapse. They're quite anticipated. Or it could be an anticipated case, like a thunderbolt, a patient going into amniotic fluid embolism. Or it could be a rupture of an aneurysm. Or it could be even a pulmonary embolism, aortic dissection. Or a simple case of a drug anaphylaxis. You want to give them an antibiotic and the patient collapses. Or it could be an overdosage of a local anesthetic. Toxicity, not an overdosage, a toxicity. Definitely overdosage will lead to a toxicity. So, other than managing the individual patient, if you want to reduce the risk, it should be thought of in a broader aspect. You identify the risk, you analyze why the collapse occurred. Of course, you give the treatment for the collapse, and then you think of how to control a collapse occurring and how to decrease the effects of a collapse if it occurs, either to you or to your colleague. And risk reduction therefore involves analysis of all obstetric collapses that could be a proactive risk assessment or a reactive risk assessment. What is a proactive risk assessment? And that is what happens in what that we daily do. In a case of a thing which happens in the, this is a prospective identification of events before that occurs. If you think about a labor room, supposing a PPH comes, then once the patient starts bleeding, you should be making an assessment in your mind that this patient is liable to go in for an obstetric collapse. And how to prevent it? There comes your guidelines, help of your guidelines and care bundles, conducts of workshops and simulation drills. And this will reduce the risk of a collapse occurring. Now, what is this reactive risk? In reactive risk, it is the retrospective analysis of a collapse. The collapse has already occurred. You were not able to prevent. Still, there is something to learn from it so that you can prevent further mishaps. You identify the root cause and do an analysis and identify whether there was a cause of a substandard care in that, whether a better care could have prevented the collapse, and whether there were any contributory factor like lack of sufficient staff, like lack of an equipment, like lack of an infrastructure, availability of blood, whether there were any contributory factors, and from this, you generate recommendations and solutions. An obstetric collapse which has already occurred can still teach you to tell you what lessons you learned, and thereby you develop these protocols and guidelines, and these protocols and guidelines will help you in the proactive management of an obstetric collapse. And you disseminate the knowledge through workshops, drills, meetings. That is why I am here, and that is why all of you are here. And thereby, we reduce the risk of a collapse recurring. So you prevent a collapse occurring. If it all occurs, then prevent it from further recurring. And now, supposing we want to apply this to a practical solution, how a proactive risk analysis can help you, it's a case of, take the case of a postpartum hemorrhage. We know the collapses occurs not because we don't do anything, but we do too little or too late. That's a basic thing behind any mishap. So in a case of a PPH, what is this too little? We underestimate the blood. We know if 500, we say that 500 ml would have been lost. We know it is not 500 ml, it is 1,500 ml. And that is underestimation of the loss. And then we do too little. Once a patient delivers, what do we do in fourth stage of labor? Many patients have been found in collapse in the fourth stage of labor due to unidentified bleeding. And then once the blood is lost, we know we have to replace it with blood. But till the blood comes, what do? We should have the knowledge that we should replace with intravascular volume. We do too little there. And then commonest cause is an atonic PPH. And we should have definite idea how much of oxytocics at what time, what to repeat, and when to stop this medical management. We give too little of oxytocic agents, not in the correct dose and not the correct agents. And then we know once the blood is lost, we have to replace it. And we know that not only RBCs are needed, once the blood loss is severe, it goes into dilutional coagulopathy, DIC. So in anticipation, blood products also has to be arranged. And then we should know where we do too little in resorting to, too little and too late in resorting to surgical management. And when it's beyond our control, we should refer the patient. So all this knowledge should be there in reactive analysis. And accurate estimation of blood loss is vital in preventing obstetric collapse. And visual estimation, we know, is not good. And a young, fit lady, the vitals become unstable only when 30% of blood is lost. So what knowledge we should have? We should not rely on vital signs. We should rely on the visual estimation. So what comes to our help? The knowledge of a shock index. Pulse upon blood pressure. If it is more than 0.9, to put it simply, when pulse goes above your systolic BP, you are in for trouble. Or the rule of 30 will help. That is, a fall in hematocrit by 30%, your blood systolic BP will be 100, but still the patient may be going in for a collapse because her original BP was 130. An increase in pulse rate, a pulse rate of 100, we cannot be complacent because her original rate could have been 70, and increase in respiratory rate. So a systematic management is enough and is necessary in saving collapses in PPH. And therefore, from our experience, we have devised things and we have the knowledge. There's a paradigm shift in the management of PPH. Whatever be the cause, we know that arresting bleeding is the keystone to success. And thanks to Piley sir, Dr. Samartha Rampanikar, we have a lot of equipments. Transvaginal uterine artery clamp, aortic clamp, the suction cannula. But we should have the knowledge that we should have all those in our labor room. That is how we can mitigate the effect of a collapse in PPH. Now, in APH, we know we have to deliver. If it's an abruption, deliver the fetus and the placenta. We should not delay the delivery. And in massive abruption, even if the baby is dead, we should consider cesarean section if vaginal delivery is not imminent. And we should anticipate DIC, early and aggressive treatment. These are some of the things we put into practice in some of the cases. Early and aggressive use of blood products. Cesarean delivery should not be delayed for the correction of DIC. It should go hand in hand. And therefore, this was proactive. We were contemplating on a collapse. And supposing the risk has occurred, how do we mitigate the risk? It's an infrequent event, but very challenging. Preparedness is for resuscitation in terms of skilled personnel and equipment is mandatory. Because once the collapse occurs, resuscitation is the keystone to success. And therefore, the resuscitation team should be available round the clock. You won't have time to call an obstetrician. So the people who are in labor room, the staff should be trained. That comes the necessity of a obstetric rapid response team development. And thereafter, the multidisciplinary team and ICU setting. And our commonest condition where and collapse occurs all on a sudden is an amniotic fluid embolism. We know treatment, no treatment, only the supportive measure. And we know the prompt resuscitation will determine the outcome, therefore the need of an ORRT. Thereafter, the complications after AFE necessitates a multidisciplinary management. Here, the delivery of the baby is important, not for saving the baby, but for saving the mother. Taking off the iotocaval compression makes the resuscitation easier, and therefore comes the role of a perimortem cesarean section. The obstetrician in the labor room should have this awareness that she has to do a perimortem cesarean section, should have the skills, should have the equipments. Running around will definitely increase the risk of the collapse which has occurred. And thereafter, can we stop there? No. There follows a array of complications. Atonic PPH, be prepared. And coagulopathy sets in, therefore early aggressive treatment of coagulopathy. How do we prevent? The CRMD lessons will help you. And we know that no smooth muscle relaxants are to be administered in active labor. Do not do an ARM in a closed cervix, because that back pressure can cause an amniotic fluid embolism. Avoid stimulating a uterus simultaneously with multiple agents. That hypertonicity could be a reason for amniotic fluid embolism. Hyperstimulation with a dilated blood vessels is a deadly complication for an amniotic fluid embolism. Avoid vaginal misoprostol. Now, mitigating risk in anaphylaxis, you should know that it is adrenaline. You should know the strength, you should know the route, and you should know the route and the dose. And how to prevent no parenteral injections in outside hospital settings. Even a sensitizing dose can cause a collapse. And drugs for resuscitation should be ready even before you give the sensitizing dose. And all injections are to be given in the supine posture. So to mitigate the risk of an obstetric collapse, what should be there? We should be prepared. We should have trained. You yourself has to be trained. You should have trained staff. You should have the equipments and infrastructure. And the prompt resuscitation is the one which saves a patient. You should have an inbuilt ORRT team, and followed by a multidisciplinary management. Death, once the death or near miss occurs, you should be prepared to analyze and learn from it. That is what our MDNM-SR does for us. And develop, from here starts the development of guidelines and protocols. And then we should, what we develop, we should disseminate the knowledge on a regular basis, and we should give training in forms of simulating drills, etc. Therefore, all generic life support training should consider the adaptation of cardiopulmonary resuscitation in pregnant women. All maternity staff should have annual formal multidisciplinary training in support and management of maternal collapse. Life support training will definitely improve resuscitation and will decrease the risk of an obstetric collapse. And you can see here, Dr. Sita, who is our obstetrician, is giving the respiratory support, teaching the respiratory support. It is not that we have to involve an anesthesiologist for that. Unless we are trained in doing that, a patient who collapses, if she has to get the attention, we should be trained. And small group interdisciplinary training will give us more results. And we have identified that human factors are highly relevant in obstetric mishaps. Substandard care is a significant contributor. We either fail to recognize the warning symptoms and signs, as in a PPH, or any complication. Failure to recognize that once the collapse occurs, what complications can occur later, and we fail to recognize the signs of a complication. Why? Because we have lack of knowledge or lack of skills, and we fail to seek experienced input. There are seniors, either in our own institution or our knowledge, once something occurs, we should take their help also, and timely referral. And then how to mitigate the risk of and one more thing is, what prevents us from doing all this? We believe that an obstetric collapse cannot happen to us. It happens for others only. That is one thing. When we try to analyze, we think that somebody is pointing a finger at you. Somebody is trying to find fault with you. And supposing, when we ask generally to present near-miss cases, institutions are very reluctant because they think analyzing the case will be pointing fingers at them, criticizing at them. No, each of the obstetric collapses, near-miss cases that occurs anywhere, whether to you, your colleague, or your institution, should be analyzed. Then only the ongoing process of reducing risk can happen. And how to mitigate the obstetrician's risk? We have to ensure quality of care, because we have recognized human factor is very, very important in this. So quality of care through following guidelines and protocols. I have heard many people saying, I do this, I follow this. See, these guidelines are developed after studies on lakhs of patients. In front of lakhs of patients, what is your experience in tens, hundreds patients? Experiences counts a lot, but guidelines should be there to support you in medico-legal cases. And then accurate, when obstetric collapse occurs, there should be effective communication with the family members. Not that you all on a sudden go and say that the patient is no more. That nobody is going to accept. So even if you are not able to communicate with the patient, some responsible person from the team and start talking to the bystanders, relatives. And there is a way by which the problem can be delivered to them. And discussion on that is beyond the scope of this presentation. And then most important is accurate documentation of the events in a chronological order. We will get enough time for all this when we plan it. And then more than that, once an event has occurred, debriefing is very, very important. And that we have to do for the family, for the staff involved, and if we are lucky, the woman survives, to the woman themselves, what has happened and what we have done. And therefore, as a concluding statement, unfortunate events continue to happen in our field. Primary prevention is following guidelines and prevent a collapse occurring. Secondary prevention is when a collapse occurs, stick on to your resuscitation team and resuscitation. Third is tertiary prevention, the medical indemnity. And that's all. Thank you.